Hello viewers, I am Andrew Dean, Vice President of Research and Innovation at Lakehead University, inviting you to another edition of Research Matters. Today we will meet Dr. Alla Reznik, a professor in the Department of Physics at Lakehead University and a Tier 1 Canada Research Chair in the Physics of Radiation Medical Imaging. Dr. Reznik is also a scientist at the Thunder Bay Regional Health Research Institute and Senior Investigator at the Ontario Institute of Cancer Research. Welcome, Alla. We're really pleased to have you join us today. Could you perhaps just share us a little bit about your research interests and with viewers?
Certainly. Thank you very much, Dr. Dean. My research focuses on advancing diagnostic capabilities of radiation medical imaging modalities. Specifically, our group at Lakehead University and the Thunder Bay Regional Health Research Institute, the TBR-HRI, works on developing of new generation of X-ray imaging detectors as well as positron emission tomography technologies. The goal of our research is to improve visualization and detectability of small anatomical or functional abnormalities while reducing the dose associated with radiation medical imaging. And let me please explain why it is so important to reduce the dose which patient receive during diagnostic procedures, if this is of interest to you.
Of course, yeah.
So in diagnostic radiation medical imaging, radiation, that is X-ray or gamma ray photons, passes through patient body and is detected by radiation detectors. Detectors converts this radiation into a signal, and then we measure spatial distribution of the signal to reconstruct an image and to visualize a body part of interest. When we are using large dose of radiation, then the signal is strong and images of high quality. However, large doses of radiation can be harmful to human tissue. But if we reduce the amount of radiation used, then the signal becomes much weaker and becomes much more noisier, and image quality degrades. So in order to minimize the dose of radiation, however, not to sacrifice image quality, we really need to think outside the box and to develop detectors which actually count each and single X-ray or gamma ray photons. And this is exactly what my group is doing. So we are developing this next generation of detectors for X-ray imaging and organ-targeted positron emission tomography. And we were able to decrease the dose associated, for example, with positron emission tomography by 10 times. So this is a significant step forward.
So it sounds like it's really very much a balancing act, you know, how much of an image you can get or signal you can get by also reducing that radiation dose.
Exactly.
Making people feel a lot more comfortable about having those scans done.
Absolutely, because this opens a window for routine scan in pediatric, for example, population, or for screening of undiagnosed patients, for example, breast cancer screening, or emerging clinical need for prostate cancer screening. So this is very important for screening of undiagnosed patients. I mean, reducing the dose is very important for clinical implementation of our technology in screening. So,
I mean, I know your early career and where you were educated, and you started off as a pure physicist, you know, and quite often, you know, I'm a pure mathematician, and sometimes the world thinks that these careers really have no value. But tell me the journey of going from a pure physicist into someone who's working quite in an applied area of radiation imagery.
Thank you. This is a great question because, again, I was trained as a pure solid-state physicist. And solid-state physics is always associated with either consumer electronics or military applications. But I was quite fortunate because after I completed my PhD in solid-state physics, I received an offer from General Electric Medical Systems in Israel to work on their, first time ever, solid-state gamma camera for molecular breast imaging. We developed this molecular breast imaging gamma camera and sent it to clinical evaluation to Mayo Clinics. And shortly after that, we received an official letter from Mayo Clinics team that stated that due to the advanced diagnostic capabilities of our technology, the patient treatment plan has been changed. And I asked my boss what that meant. And he told me, apparently, you saved somebody's life. And it happened that this patient has recurrent cancer located very close to a surgical scar from a previous breast cancer surgery. And this surgical scar masked this recurrent cancer on mammography. But a fundamental beauty and power of molecular breast imaging is that it can reveal cancers hidden on mammograms. And this was exactly the case. And this was so emotional experience for me that I thought to myself that I will remain in this field. And I remained in this field in my entire career, even after I left the industry and came back to academia. And another quite important stage in my career was postdoctoral work at Sunnybrook Research Institute in Toronto, because it exposed me to healthcare problems. And I started to realize that healthcare needs are not always 100% aligned with perspective of a large manufacturer of diagnostic equipment, because large companies are interested in manufacturing large, very expensive technologies, like, for example, general purpose PET-CT or general purpose MRI, with an idea that one design fits all possible clinical application and all different cohort of patients. But this is not really aligned with current trend in personalized medicine and precision medical imaging, because precision imaging, in contrast, requires imaging technology to be tuned to peculiarities of a specific cohort of patients and peculiarities of different diseases. And I realized that this might be my niche, and this is exactly what our group at Lakehead University and the TBRI are doing. We are doing customized technologies. So, for example, we customized positron emission tomography technology to be organ-targeted or disease-targeted technology. We started from breast cancer detection, and now we are expanding toward prostate cancer detection, as well as evaluation of neurodegenerative diseases.
It must be very, very fulfilling to see the research that you've done, the training you've done, actually translate into something where someone says, you probably saved a life,
Exactly.
That's good. You're a Canada Research Chair. We've had Canada Research Chairs on this program before, but you're a Tier 1 Canada Research Chair. We have very few of those. Can you tell us a little bit how the Canada Research Chair programs have been able to do your research?
It is very, very important for me. First of all, I received some financial package, which helps sustain my operation, to cover partially student stipends and partially to cover expenses on different parts of my research. And also prestige of Tier 1 CRC helps to establish very strong collaboration with leading healthcare institution in Canada and abroad, and maintain this collaboration, and to attract research funds, and what is very important, to attract top talents to my group.
That's wonderful. Okay, well, thank you for introducing us to your research. We're going to take a short break right now, and we'll be back to continue the discussions with Dr. Alla Reznik about her research and program. Thank you. Welcome back. You're watching Research Matters, brought to you by Lakehead University. Before the break, we were introduced to Dr. Alla Reznik and her research interests. In this segment, we're going to learn more about her ongoing research on radiation medical imaging technology. So, Alla, your latest research projects focus on low-dose organ-targeted positron emission tomography, or PET imaging. Can you share a bit more about that?
Absolutely, with pleasure. So positron emission tomography is a well-known medical imaging modality. It is called functional modality because, in contrast to anatomical imaging modality, it makes image based on functional abnormalities of different organs. For example, if we are talking about cancer, it utilizes the fact that cancer is more metabolically active than normal tissue. And basically it becomes metabolic imaging. So the physics, I'm a physicist, so in 2 words, the physics behind this imaging. Again, cancer is metabolically more active than surrounding tissue. So we used this metabolism to visualize, increased glucose metabolism to visualize cancer. For this, we're using radioactive analog of a sugar molecule. So it's basically just radioactive glucose, which we inject intravenously. And then this radioactive glucose, it's called radiotracer, is concentrated, accumulated where cancer cells are located. And this increased uptake of radioactive glucose in a tumor makes tumor more radioactive than surrounding tissue. And then what we need is to use positron emission tomography detectors to visualize this excessive radioactivity which comes from the tumor. Normal whole body general purpose positron emission tomography scanners utilize ring detector approach, where patients are scanned from head to toe. And this is very important when we do not know where to search, for example, like in case of metastasis. But when we do know where to search, like in case, for example, of breast cancer, we do not need to use general purpose machines. We may use something like that. This is our device. This is an exact model of our device. The size is like the size of this chair. And you can see these 2 detector heads. These are planar detector heads, and we can place them very close to an organ of interest. For example, for breast imaging, we place them very close to slightly immobilized breast, so we do not need strong compression, typical to mammography. And because we place detector very close to an organ of interest, we collect signal much more efficiently than general purpose machines. And also, we reconsidered one of the crucial components in conventional PET technology. This is vacuum photomultiplier tubes. Vacuum photomultiplier tubes are from the era of CRT televisions. Do you remember these bulky, large CRT televisions, which are already years ago replaced by solid-state technologies? And this is exactly what we did. Instead of bulky hardware, we are using solid-state electronics. I'm a solid-state physicist, so everything has to be solid-state in our laboratory. And these are very slim, flat panel detectors, which allow us to place them much closer to an organ of interest than conventional technology does. And as a result, both our patented design and those advanced components, we were able to reduce the dose of this radiotracer by 10 times. And this is confirmed by clinical trials. So we accomplished the first stage of clinical evaluation at the Princess Margaret Cancer Center, and the results exceeded all our expectations. We were able to detect cancers which were hidden on mammograms. We were able to correct for false positives of MRI. And everything has been done at 90% reduction in the amount of radiotracer used. We published results in radiology. This is a top journal in our field. And very shortly after that, we received news that Radiological Society of North America posted an article on us telling that this is really breakthrough in positron emission tomography technology. And we spun off a company, Radialis, that is a spin-off company of Lakehead University and the TBR HRI. Radialis commercializes our technology, and I am very happy to report that commercial version of our scanner has been installed in the Thunder Bay Regional Health Sciences Center, and we are looking forward to start clinical evaluation there very soon as in February. And the scope of this clinical evaluation will be around evaluation of the efficacy of systemic breast cancer treatment before breast cancer surgery.
So it sounds like not only has your design and the science of that also reduce the amount of radioactivity tremendously. It sounds like it's much more comfortable.
It's comfortable, it's no pain, it's 5-minute scans, the images are displayed almost immediately, high patient throughput, and it's just a fraction of the cost of general purpose whole body PET machine.
You mentioned about radial tracers. Are you able to get those here?
Yes, we are able to get these radial tracers because we now have our cyclotron. And it will be used for clinical evaluation here locally. So it will be our local technology and local radio tracer.
Fantastic. So we know that research, certainly research where you have many, many students and employees, really can't take place on its own. It needs funding and that. You mentioned your partnership with, or being a senior scientist at the Research Institute. Can you tell us a little bit more of the funders and more of the partners that you work with?
Yes, thank you. So we are very happy that we were able to receive financial support from NSERC, from the CHR, and from provincial grants like Ontario Institute for Cancer Research, Terry Fox Research Institute, MITEX, and of course Ontario Research Fund's Research Excellence Program. These are very important to sustain and to grow our operations.
And so where do you want to go next with your research? I mean, it seems like it's always evolving.
Our research journey will be continued because even if you have a killing technology, this is not the end of your journey. You need to implement it clinically. And this is not easy because first you have to identify barriers for clinical implementation. For example, how to incorporate your technology in the current workflow. And we are working with early technology adopters who are hospitals which are evaluating our technology to identify those barriers and to work toward incorporation of our technology into clinical practice, reimbursement code, for example, or who will make referral for the clinical use of our technology, family physicians or mammographer after suspicious but inconclusive mammograms. So these are all questions which we need an answer. And of course, as a physicist, I'm not knowledgeable in this area, and that is why very strong partnership which we established with different health institutions will be crucial in order to first identify and then overcome these barriers for clinical implementation of our technology.
I think a lot of people don't realize just how long it actually takes from an idea to a commercial venture in the medical technology field. You know, this is what I say. They say it's a 10-year journey, and
at least,
you know, it takes a lot of perseverance. I know.
And dedication.
And dedication. Okay, we're going to take another short break, and we'll be right back to continue our discussions with Dr. Reznik and some of our current and former graduate students. Welcome back. So we're again joined by Dr. Alla Reznik, but also by Henry Maa-Hacquoil and Sasha Bubon. So, Henry, welcome. And can you share us a little bit about your educational background?
Of course, Dr. Dean. So I'm currently doing a Master's of Physics with a focus on medical imaging supervised by Dr. Reznik, but I think my education in physics began in early as high school when I was employed by Reznik Labs as a high school research assistant as part of their summer school of medical imaging. So this gave me the opportunity to both do research and have sort of like a first view of how physics can be applied in the career. And then from there, I did my undergraduate at Lakehead University in mathematical physics, with my honors once again being supervised by Dr. Reznik and Dr. Bubon. And as part of my honors, I was able to work with the radialis PET machine that Dr. Reznik showed earlier, working to continue to make improvements to the PET camera. And as part of my honors, I focused mainly on improving the performance of the PET detector, specifically one of the components, which is known as a light guide. It's a solid piece of borosilicate glass which is used to take optical photons or visible light that enters the PET detectors and help direct it towards the solid state detectors. And thankfully, the honors was very successful. We were able to see improved performance in the PET detectors, and the components are actually currently have been installed as part of the detectors in one of the machines currently at the lab, which underwent testing and will soon be used in a clinical setting.
So you said you started off by having your interest maybe peaked a little bit by going to this summer school of medical imaging. But did that actually happen at that time? Was it exciting?
Oh yeah, certainly. Like I want to say grade 11 even, so very, very young, at least for a lot of the students that are at the lab, but it certainly did help push me in that direction because I was able to see that taking physics in university could lead directly to career paths. I was able to have a first-hand view of how important of a role a physicist could play in the industry, like how my contributions would have direct impact on like patient care. It would have benefits in society. Like sort of everything was by the end of the summer school was pretty clear to me. So it helped to push me in the direction of doing an undergraduate and then a master's, and then hopefully maybe a career later on in the field.
It must be quite exciting also to have in your master's the ability to be very applied with the research, but also getting that training as you're going along.
Oh yeah, certainly. Like right now with my master's, I'm actually working on part of my master's is working on simulations of these PET detectors in order to help better like design new work on new designs for them to further improve the performance. So of course that requires me like learning things in computer science, physics, different simulation softwares, all of which will most certainly be useful in a career later. And of course, I also am able to get constant updates on the performance of our current machines, and which I can help part to design and test. So I also sort of have these real-time updates of how my work is having real, meaningful clinical impacts.
That's fantastic. Welcome, Sasha. So you recently completed your PhD with Dr. Reznik. So what did your PhD research focus on?
Thank you, Dr. Dean. My PhD was very kind of two-folded. So I had a main goal for my PhD is to improve healthcare, and in terms of my PhD particularly, we're looking into breast cancer, and we were looking into whatever science can provide new to the medical imaging community in order to be able to address unmet patient need for high-risk population and for imaging with mammography, for example. And since mammography was a gold standard, and it is still a gold standard, we looked into X-rays. And Dr. Reznik mentioned earlier that her lab was also working on the X-ray detectors. So me, as a PhD student, I took the best available X-ray detector at that time for X-ray mammography, which was amorphous selenium, and we started working at it. And we looked into what is the biggest impact we can make by maybe decreasing the dose or increasing the sensitivity of that detector. So I spent first year of my PhD working on the amorphous selenium. We designed a amorphous selenium detector that can be scaled up in the future for high sensitivity X-ray mammography application. Unfortunately, it seemed to be a little bit more challenging for a small group like us to bring it all the way into the device, just because it's a very deep material science, and we did discover a lot of theoretical knowledge there, but we did want it to go into something that we can move forward into the real world scenario. And in my case, it was positron emission tomography detectors. So we knew that there's a very big gap for the high-risk population in women who are imaged with X-ray mammography, where X-ray mammography doesn't work that well. And that gap, we believe, can be filled in with the functional imaging. And the functional imaging is positron emission tomography, as Dr. Reznik mentioned it. But at that time, when I did my PhD, there were no really a device that can address this need. So there were whole body PET scanners, which has their own drawbacks, extremely costly, accessibility is very low, and the biggest problem for all of them is a very high dose associated with that. And when we talk about potentially healthy population, and we talk about applications like screening, then we can't really put in the same equation high dose and screening. So I decided to focus the next couple of years of my PhD and direct them into improving this particular modality and designing detectors and the machine that will allow us to enable low-dose screening. And this was the ultimate goal of my PhD. So I went back to the drawing board with Dr. Reznik. We had a lot of brainstorming sessions and discussions, and we came up with an organ-targeted solid-state positron emission tomography system, which can be showcased in various scenarios recently. And during my PhD, I had an opportunity to design it from the drawing board to the detectors, then we walked it from the proof of concept and then into the actual clinical ready prototype. And by the end of my PhD, the machine was installed in Princess Margaret Hospital. And when I graduated, we were just waiting for the Research Ethics Board approval in order to do our first patients. So there was a very interesting journey during my PhD for sure.
That's fantastic. So now you're the Chief Technology Officer, or CTO, and co-founder of Radialis. What do you do in those roles?
Probably a lot of different things that I did not plan on doing. It's definitely what I found myself is that I'm being challenged every day and every hour of the day when I'm working at the Radialis. So my learning journey have not stopped. I have to embrace new sciences and new knowledge all the time. I do really appreciate the opportunity that Radialis and this position gives me in order to work with our collaborators, work with junior talent, as well as being able to lead the company where I think that it needs to go, and having a good guidance there as well from the rest of the team. I do also think that I don't think I ever had an opportunity in Radialis' position to wake up in the morning and think and say, I don't think I have nothing to do. It's always there's a huge list of the tasks that you have to accomplish, and there's no going back. And I feel like it's a different world for sure. And I feel like full responsibility that I have to do it. There's no coming back. And I'm really happy that I have a chance to work with very closely with Lakehead University and Dr. Reznik lab, and have unconditional support of students who get to work on the projects which are adjacent to the Radialis, as well as be able to guide them and direct them into the more applied applications of medical imaging.
Probably a little bit more auditing and paperwork than you ever thought, though.
Unfortunately, quality of the devices and the quality management system comes hand to hand with every aspect of work that we do. And it does create a lot of paperwork. It does create a lot of commitment from the team and management, but we're there. I'm very happy to say that we are not only ISO compliant as a medical device manufacturer and FDA licensed facility, we're also compliant with MDSAP, which is part of the requirement to be Health Canada compliant for the medical device manufacturer.
Well, thank you very much, Alla, Henry, and Sasha, for speaking with me today. Improving patient care is an important focus of medical technology research. As we heard in today's interview, there are many factors to consider to ensure that new medical technologies can actually be implemented in clinical practice in a way that is not only cost-effective, but easy and less pain for patients to access. Thank you for joining us today on the Research Matters. Until next time, my name is Andrew Dean, Vice President of Research and Innovation at Lakehead University. That was great.